Before we start today's episode, I would like to quickly read you our podcast disclaimer. The content in this podcast is for general reference and educational purposes only. It is not meant to be complete or exhaustive or to be applicable to any specific individual's medical condition. No information provided in this podcast constitutes medical advice and is not an attempt to practice medicine or to provide specific medical advice, diagnosis, or treatment. This podcast does not create a physician-patient relationship and is not a substitute for professional medical advice, diagnosis, or treatment. Please do not rely on this podcast for emergency medical treatment. Remember that everyone is different, so make sure you consult your own healthcare professional before seeking any new treatment and before you alter, suspend, or initiate a new change in your routine. Welcome to The Starting Gate. We're your hosts, Dr. Kitty Dotson
and Dr. Sarah Sheets,
two internal medicine doctors who spent years practicing traditional primary care. Over time, we realized something was missing from modern healthcare. A real understanding of how everyday lifestyle choices impact overall health.
We'll help you cut through the noise of the countless health influencers and their conflicting opinions, because no matter who you follow, the basics of lifestyle medicine are at the heart of it all.
Welcome to The Starting Gate. We're your hosts, Dr. Kitty Dotson
and Dr. Sarah Sheets. Well, today we're diving into a topic that sits at the center of many chronic diseases that we see today in healthcare, and that's insulin resistance. And that's whether we're talking about prediabetes, type 2 diabetes, things like PCOS, cardiovascular disease. Insulin sensitivity plays a huge role in all of that. So we really want to break down what is insulin resistance, as some of our listeners may be thinking right now, why that matters, and how lifestyle can play a huge role in improving it. We also want to talk through some practical strategies that are evidence-based for people who live with diabetes and things that they can be doing to make those small steps towards getting better control of their health.
And to help us with all of this today, we're so excited to be joined by Dr. Chhaya Makhija, who is a triple board certified endocrinologist and lifestyle medicine specialist who is joining us all the way from California. Thank you so much.
Thank you.
And she is a wealth of knowledge. We are going to learn so much from her. She has her own practice called Unified Endocrine and Diabetes Care and really blends managing the science of hormones and metabolism, as well as all these lifestyle practices that we love to talk about, kind of the Eastern and Western medicine mix, and has her own podcast, which you probably will want to start listening to after this, called Hormones and Hope Podcast, and aims to have a lot of the same goals that we do in helping people take charge of their own hormonal and metabolic health. So thank you so much for doing this with us today.
Woohoo, thank you. I've loved to share the education piece of endocrinology, and it's such amazing platforms that you as physicians have created. So thank you for having me.
And for our listeners, just give us a little bit of background on how you became an endocrinologist and then how you became interested in lifestyle medicine.
I was born and raised in India. In India, we just have two professions that parents will allow you to get into, either an engineer or a physician. But I wanted to be in this field because growing up, aged 8 or 9, I saw my grandma, who we still don't know had type 1 or type 2 diabetes, but was insulin dependent at that time. And I watched her injecting, went to physician offices. I watched her get the toe amputation, then the forefoot amputation, and then above knee amputation, and then end-stage renal disease within a short span of 1 year. And that triggered, these questions that you start feeling like, I'm inspired. I need to do something for this condition or for diabetes. And at that time, we didn't have endocrinology fellowship as such. We had more diabetology, diabetes specialist. So that piqued my interest further when my mom had Graves' disease. So this was in her perimenopausal phase. And that's what I discovered, even before medical school, that, oh my gosh, this is all endocrinology, which is science of hormones, diabetes, and metabolism. And that took me to pursuing medical school and then internal medicine residency in New Jersey, and then diabetes, endocrine, and metabolism fellowship at University of Nebraska, which was another 2 years. But in between, I also did some diabetes research, basic research at Albert Einstein in New York, which really helped me understand that it's not just the cellular, the biology of insulin and pancreas, but there is something else which can help our patients to work towards prevention of diabetes. And here I am today, age 45, almost 12, 13 years post-fellowship, where I'm truly practicing what I dreamt in medical school. That is prevention of type 2 diabetes, insulin resistance, and more that we'll talk in depth today. The second piece is lifestyle medicine, right? That is also ingrained in my upbringing. My father had multiple myeloma. He dealt with it for 15 years very bravely and with a lot of lifestyle medicine intervention tools other than the chemotherapy or, immunosuppressants that were needed. But that helped to live the best quality of life. And when I mean by that, lifestyle medicine is not just broken down into exercise more and eat less or eat well or eat a balanced meal, but also our social connection, also what I think about myself and the disease that I'm dealing with. Can I separate those two? And I can myself become my advocate or my physician and take care of my body. Or I become the nurse and take care of the body, and the body may come with, certain diseases or conditions. The other part was, the sleep, the surrender part of it, and that community of seeking support with family, with your friend, is what I marvel about how that quality of life really magnified during those 15 years. And, at that time, you're just dealing it with as a daughter and who is in medicine, trying to do her best as much as she could in terms of helping with the conversation between physician and the patient. But after he passed away, I really dived into how can I incorporate these pillars that improve the quality of life into diabetes world, into prevention of osteoporosis. And I came across the ACLM board certification, which specified, clinical evidence-based medicine, which is lifestyle, how it can be incorporated. And I was just amazed that we already have so much data, so much science backing it up. So why not actually bring it in practice with my patients?
We love talking to lifestyle medicine physicians because we all find it by searching, right? We're just like, hey, I'm looking for this. And then you feel like, oh my goodness, I've been looking for this. This is exactly the answers that I've been searching for. So I feel like we all have a similar story when it comes to like, how did you become a lifestyle medicine doctor? Well, to get us started, let's just define what is insulin resistance versus insulin sensitivity. And I think that can help our listeners kind of understand where we go with the rest of our conversation.
Absolutely. That's the billion-dollar question, I would say. The foundations of lots of chronic diseases that we should be very well aware of. And just, with medical textbooks, we only thought about insulin resistance and diabetes. Until recently, I would say in the last 15 years or so, there's more awareness and also more conversation happening with every specialist about how it's linked to chronic diseases. So what is it? Just by breaking the terminology, insulin is a hormone and resistance is basically a barrier. Our own insulin is getting some hindrance or a hurdle to actually get its action within us 100% or absolutely effectively. All right, so why is insulin important? Now, one of the key things to remember is there are 3 hormones which are essential for sustenance of life. One is thyroid, the second is insulin, and the third is cortisol. Like we cannot live or sustain life without these 3 hormones. And so insulin is very essential. In individuals who don't synthesize any amount of insulin, they have type 1 diabetes, and that's why they need insulin in terms of their treatment, which is life-saving. Then comes another set of group, our patient population, which initially we thought was prediabetes and type 2 diabetes, and they have a root cause, which is insulin resistance, meaning their body is producing insulin and it is working towards telling their cells that, hey, utilize glucose as your fuel, as your main engine oil. And if that is happening, there will not be excess glucose circulating into your bloodstream. So insulin helps your fuel to get inside the engine, which is your cell. All right. So now when we know that basic mechanism, what happens with insulin resistance is that same insulin now needs to double up, triple, quadruple, sometimes even 10 times higher, that it has to work harder and be produced in a larger amount to tell the same glucose molecule, the same fuel, that, hey, let's enter the engine and let the engine work smoother and at a good pace. So when that happens, it's called hyperinsulinemia. There is some insulin resistance, meaning my body is working harder, my pancreas is working harder to push that same fuel inside my cell. Now, what does that mean for a human being? Like, why do I care about this stuff? The reason you care is your pancreas has just enough beta cell reserves, meaning it just has enough cells to produce enough insulin. You're utilizing those same cells faster and more rapidly. So the death of these cells may arrive sooner than later. And what does beta cell death mean? Meaning we may have to be on insulin as a treatment if we eventually have type 2 diabetes and if we have lower and lower beta cell reserves, right? So you may not feel symptomatic or you may not have any clue that you are you dealing with insulin resistance, but it is the foundation to cause heart disease, to cause vascular inflammation, to cause fatty liver disease, prediabetes, and type 2 diabetes. So coming back to your original definition, insulin, when it's working harder and it is unable to enter into the cell to help our glucose be utilized for that cellular metabolism, there is insulin resistance. Insulin resistance may not make you feel any different, or it may, depending on if it's causing a disease. But there are certain signs that we as physicians, when we're examining you, can tell that, oh, there is this sign for insulin resistance. So say you want to know, and you're, that, hey, do I have insulin resistance? There are two ways. One is many of us may have clinical stigmata, as how we call, or signs or features on our body. Skin tags, mostly on our neck or the back of the neck, and sometimes even on the chest. The second thing is a darkening of the skin in the creases. So front of the neck, which I commonly see, including the back of the neck, which is called acanthosis nigricans, basically dark velvety areas. But as clinicians, we also know that they could be fine lines. They're just building, and that could be a sign of insulin resistance without even looking at your blood work or biochemical evaluation. The other areas that we commonly see is, under the groin, under the breast, where we may see some similar features. The third one is, surprisingly, we don't talk about it as much, but the changes in our waist circumference is also dictated by insulin resistance. And there are other conditions which will have a similar presentation, but that's another way to know that, okay, there is this insulin resistance component which is contributing to a larger waist circumference in those individuals. Now, there are other features that we could dive into, but for anyone as a human being who's not into medical profession, these are good ways to know that, do I have any signs or stigmata for insulin resistance? For us, there is quite a lot of work done in the last 50 years on insulin resistance.
So if someone is looking for kind of a definitive diagnosis, what is it that you would recommend?
Sure. So we can have the umbrella of insulin resistance and still don't have diabetes, or we may have prediabetes, or we may have type 2 diabetes, or we may have type 1 diabetes and we're insulin resistant. So we are right now talking about insulin resistance as an umbrella just for the diabetes world. Or, you could also add gestational diabetes in there, where they could be an overlap or an umbrella or a root cause, which is insulin resistance. So in general, other than the clinician looking at certain clinical features, if you were interested as a patient or as a clinician, we all are aware of the calculation of insulin resistance, which is the HOMA-IR model. It's basically a homeostasis model. But in simple words, what I would describe this as, have your clinician, or we as clinicians, what we do is get a fasting insulin and a fasting glucose simultaneously. And then you have a calculation, or, just go search on Google HOMA-IR calculator, and you'll find the insertions where you put your fasting insulin and your fasting glucose. Now, in general, what the studies say that if your levels are greater than 11 or 13, you have mild insulin resistance, and then the score goes up higher, your insulin resistance category gets higher. But in clinical scenarios, I don't sit and calculate everyone's HOMA-IR by calculating into the specific calculator. It's very obvious. If your insulin is in single digits, and your glucose is normal, fantastic. Okay,
Yeah.
single digits, not 10. If your glucose is in the impaired level, that is between, I would say 100, not even 101, because that's the fine line. But see if it's 101 to 125, and your insulin level is in double digits, or it's getting 9, 10, higher, bingo, you have insulin resistance with that impaired glucose tolerance. And of course, in our patients with type 2 diabetes, or just with magnification of insulin resistance because of ethnicity, because of hereditary risk factors, their glucose may be phenomenal, but they come in with insulin levels of 30s and 40s. And the referral coming from primary care physician is that they're worried about insulinoma. Insulinoma is a condition, it's a tumor where the pancreas is pathologically producing too much insulin because of a tumor. And that's where the insulin levels are higher. In those patients, if we go back to what we learned in the initial part of the conversation today, is insulin drives your glucose into the cells. So it is supposed to normalize your glucose. So patients with insulinoma, too much insulin in the blood causes too much glucose to go into the cells, causing low blood sugars. Whereas insulin resistance is also producing too much insulin, but it is inadequately capable to push that glucose inside the cells. And eventually you may have normal glucose to slightly higher glucose to higher blood glucose in the bloodstream. So that's the difference between, insulin levels in insulinoma versus insulin resistance.
So something that you said that some of our listeners may have experienced, a lot of times they are not getting these fasting insulin levels, but maybe they're getting just a fasting glucose or A1C, and say someone is in the normal range for those. What your reflection was, that doesn't mean necessarily insulin resistance couldn't be there. That's something that we like to check, but that is not something that everyone gets at the primary care office on a regular basis. An A1C, which a lot of people have had at some point. Can you explain how we can use that number to understand if insulin resistance is starting to occur?
Hemoglobin A1C, and we don't have to be fasting for that test because it's an average of 90 days to 120 days of glucose averages. So it's a percentage, right? Focusing here on A1C, there are a lot of nuances that the more and more values we see, we start questioning as clinicians, and especially in endocrinology, that can I trust this hemoglobin A1C? So I'll give you some scenarios. Hemoglobin A1C is hemoglobin molecule, which is glycosylated, meaning just imagine I have a molecule of hemoglobin and that has a lot of partners or friends around its circumference, and those are all glucose partners. So now hemoglobin with the glucose partners is called as hemoglobin A1C. That can be impacted because either the hemoglobin is low or the hemoglobin is high. So what is your hemoglobin? Hemoglobin is basically calculated in your CBC, your blood count, and it reflects if you're anemic versus you are not anemic. But also individuals just with iron deficiency, their hemoglobin may be fine, they may have iron deficiency. Or someone with B12 deficiency, hemoglobin may be fine, but they have low B12. I see that A1C gets abnormally impacted, and we are misinterpreting that data also. So whenever you get A1C, hemoglobin A1C, always get a glucose value with it, and that could be a fasting glucose itself. And then, tackle it. If it's abnormal, look through your postprandial glucose levels too. So I'm giving you the nuances first because it's very easy for us to look at a table and say, hemoglobin A1C of less than 5.6% or lower is normal. Hemoglobin A1C of 5.7% and 6.4% is prediabetes. Hemoglobin A1C of 6.5% or higher is diabetes. It could be type 1 or type 2 diabetes, right? So those are simple breakdowns. But what happens if someone's A1C would be 6.4%? The lab doesn't calculate it, but technically they have diabetes. What if they are at 5.65%? What if they are at 5.6%, but their hemoglobin tends to fluctuate, or they just had an iron infusion recently, right? We need time to discuss that with patients if you're seeing them for the first time or just for a glucose evaluation. That's why when we're looking at someone who has stigmata of insulin resistance or has family history of diabetes, or has multiple pregnancies with gestational diabetes, or even ethnicity, they're Hispanics, African Americans, or even South Asians, I would highly recommend to look beyond A1C and correlate this level. American Diabetes Association suggests to rely on your A1C data, and if that is not reliable or it's inaccurate, then go towards looking at 3 fasting glucose levels or just get an oral glucose tolerance test, which is basically a gold standard test in terms of detecting if you have no diabetes, pre-diabetes, or diabetes mellitus.
And for somebody that does have insulin resistance or prediabetes or diabetes, can they improve it?
Absolutely. 100% yes. And that's what I do in my daily work with patients. And, we've published this twice now at American College of Lifestyle Medicine, like the national meetings and posters, like why it's so essential. The reason I say yes is we're talking about pre-diabetes and type 2 diabetes, right? When we were in medical school, finished my medical school in 2004. We only knew that diabetes is age-related condition, or, you'll start seeing the diagnosis more later part of your life, that is 60, 65. Or if you have family history, no doubt you're going to get type 2 diabetes, right? And we didn't have as much of the screening availability in terms of let's get an A1C and boom, you get your screening test and you know where you're at. We did not have continuous glucose monitors, except for patients with type 1 diabetes who were using it at that time. Now we have a lot of tools. We have insane amount of medications, people, but our diabetes incidence, specifically type 2 and pre-diabetes, is just skyrocketing. And I'm so glad that you asked this question about prevention, because prevention happens in the younger and younger age group. What's disheartening to see is our populations. If we're talking about United States of America, 50% of our population has either prediabetes or type 2 diabetes. 50%, that's the prevalence, right? And if forget about prediabetes and type 2 diabetes, we talked about the umbrella of insulin resistance. I'm not even talking about the obesity epidemic or the heart disease epidemic, right? So no matter how many medications we have, and the science is really rapidly evolving in this era in terms of GLP-1 medications, SGLT2 medications, everyone with showing the cardiovascular mortality benefits and so on. What we cannot lose, what is not non-negotiable, is our lifestyle interventions, because they still are grounded in science, and then they still show that we can prevent both prediabetes, type 2 diabetes, as well as improve our insulin sensitivity. And if you have type 2 diabetes, then remission is very much possible with the right tools.
Diabetes remission. Can you please explain what is that? Because that is
Sure.
not something that when someone receives that diagnosis, they feel like I've had this for the rest of my life.
So it's newly coined as compared to, we have malignancy or someone dealing with so-and-so cancer. And when they cannot find any biochemical marker in the blood test or anything on the imaging, the oncologist will term that this cancer is in remission, right? But that means that we still have to keep an eye on it. We still have to do some form of surveillance. You still need appropriate checkups so that we are able to capture it in case it recurs, but you're in remission. No one knows how long you'll be in remission. Now, this is specifically for how oncologists work in the world of oncology cancer. Now comes diabetes, right? Again, we are specifically talking about type 2 diabetes here. Type 2 diabetes remission, it was coined because, one, we've had a lot of supportive lifestyle interventions, which are combining not just nutrition and physical activity, but all aspects that can cause insulin resistance or that can lead to hyperglycemia beyond the foods that we are eating, right? There are almost known 42 factors that can cause high or low blood sugars. That's a great table in diatribe.org. I can share with you, created by an endocrinologist, which talks about number of factors beyond food, beyond carbs, that can cause high blood glucose. So when we are approaching care of type 2 diabetes and knowing what is the duration that that person has type 2 diabetes with lifestyle interventions, and or with or without support of medications, you're able to help them bring their glycemic control in the normal range. So it could be glucose in the normal range, and has to be A1C in the normal range, and you're able to wean off the medications. They continue to maintain their lifestyle interventions or even amplify it. And in 3 months, 6 months, they are still not needing medications. That's the term that we'll start using, that the patient is in remission for specific condition, that is type 2 diabetes. Again, just we compared how oncologists pursue taking care of these patients with a specific type of cancer. You still need to get your glucose level, your A1C periodically every 4 to 6 months to maintain the diagnosis of remission, because there is really high risk that for any reason there are stressors. You're not able to maintain those specific lifestyle interventions, that the blood sugars may spike, the glucose may rise, and the A1C may drift towards prediabetes or again type 2 diabetes.
No, that's probably one of your favorite things to tell a patient is your diabetes is in remission and we are going to monitor and keep up the good work.
I'm scared the first 3 months because they are so excited. And I was like, oh God, please understand that, you've just saved your beta cells. You can't put a lot of stress on it. Don't just go, celebration is great, but we don't celebrate every day, every minute with things that can harm us. So I'm literally praying in my heart until I see them, because we need to prolong the diabetes remission stage.
Well, let's get started with those lifestyle interventions that help. And I think the first thing most people think about when it comes to diabetes is nutrition. When I told patients they had diabetes or prediabetes over the years, I feel like the first thing they always say is, okay, so I just got to cut out the sweets or I got to cut out the bread. Is that all I need to do? What do you say to those patients?
No. One thing is that, can I just cut off sugar and I'll be fine? I'll be a good student, I'll be a good patient. And you as clinicians must have experienced that, when patients come, it's like, gosh, my doctor is going to really get mad at me. That's the common word they'll say, because I had some sugar, during the holidays and so on, right? But it's not about us as clinicians. It's about you. It's about, you as a human being. That my goal for every patient or any community member that we're having exchanges about diabetes or prediabetes in the realm of nutrition is that we don't need to restrict, right? We don't need to stop enjoyment. We don't need to stop enjoying food. But can we just learn more about what foods are good for me and what foods are not good for me? And before that, why do I need to know about it, right? I want to not have type 2 diabetes, or I don't need those complications, or my parents had type 2 diabetes and I am very much intentional of not having this condition. Or, I want to play around with my family forever and I don't need heart disease. There has to be some reason that you're asking me this question. So I'll definitely deep dive into that specific why. Otherwise, I'm just giving information. You go to ChatGPT, you go to, Claude nowadays, or even a Google Internet search. It's a great way to start that, okay, what I can eat and what I cannot eat. But most of them will say, cut down your carbs, stop eating sugar, and you'll be fine. And trust me, you'll see an improvement in your glucose if you do that. No doubt. But is it sustainable, right? Is it helping me also to improve my bowel movement? Is that same food going to help me improve my gut microbiome? Is that same food going to help me give me energy if I'm exercising? That's the food choice I need to make, not just looking at glucose level and thinking that I need to stop eating pineapple, or I don't need berries because they're also sugar and they'll raise my blood sugar. So that's the conversation that I would start with, rather than giving them, a Google answer that, yes, sugar is bad for you and stop eating it, your blood sugars will start getting better. So identifying what is sugar, what is processed sugar, and where is natural sugar. So on our packets, when they say natural brown sugar, that's not really natural. What is natural is your apples, your fruits, your bananas, your berries, and so on. So I really encourage my patients, and this is where the magic happens, because our discussion started with insulin resistance. The more fiber, the more low-fat foods, the more colorful foods, which are not M&Ms, are on your plate, you are going to improve your insulin sensitivity. That means you're going to tackle that insulin resistance. And in the short term and long term, you have a higher chance of bringing those pre-diabetes or type 2 diabetes numbers lower. So this is where I start the conversation rather than giving them yes and no answer. So you're looking at the why, you're looking at the root cause foundation that we are targeting insulin resistance here, not just a one glucose level, right? And the third thing is now looking at your plate, what it is composed of, rather than thinking about this food is bad and this food is okay for me. The fourth one is, now let's get into number one step, that can you start learning about processed and unprocessed foods? We have short videos for patients or handouts for patients, or if I'm having them see the dietitian or personally having a conversation, we start getting into a 24-hour recall. And from that 24-hour recall, look at what is processed food in this and what was unprocessed foods here, and just start building that awareness, right? So what we've done here is you're really getting into patients' life. You're really getting into their heads. You're really getting into their psychology. And that brings about a change because now they're more open to learning and themselves becoming more empowered and building that awareness, because that is going to be sustained. So nowhere in our conversation, we talked about stop eating this, you're not going to have any sugar, you're not going to have any candy, you're not going to have any cakes, that donut is going to be bad for you, please behave well, you're going to die because of so and so, nothing. So our conversations have to really be more positive, but not just positive in terms of encouragement, but in terms of awareness. Can I spend more time simplifying the education of why you're asking this question and how I can help you? Say you're on the go and you're having instant oats in the morning while you're driving the car because you have so many other things on your agenda, dropping off the kids, hitting the road and making sure you don't hit the traffic, the morning peak hour traffic, making sure that you're very well prepared for your first meeting and so on, or your first class if you're in education. So where is that first few hours, which is like really worsening your insulin resistance? Again, I didn't talk about which is worsening your glucose, which is worsening your insulin resistance. So I picked like 4 or 5 things in this conversation, and I haven't even gone through the rest of the 24-hour recall, right? So that's where we stop. That, can we negotiate, or can we have something that we could be on the same page of? Can we start prepping maybe steel cut oats? Forget about steel cut oats. How about rolled oats? They're easier. Can we start adding some chia seeds into it? What are chia seeds? Well, we'll get into it. Then I give them, certain aspects of it's an antioxidant. It swells when you just let it soak in water. You can make your pudding. You can make it fun. You can add some berries to it. You can add some nuts to it. So now you're getting into foods that are rich in fiber, low in fat. And they're still sweet because we're adding fruits to it. And we're targeting your morning routine where you're building your insulin sensitivity the first thing in the morning. The second thing is we're on the go. So other than nutrition, can you spend 2 minutes or maybe 5 minutes actually sitting down and having your breakfast? Is that a possibility? Maybe not every day. Maybe on the days you're having your first class in the morning or your first meeting in the morning, fine. I'm okay with you eating in the car. But on other days when you don't, can you be very intentional and start eating it just before you sit in the car, right? So we are helping that cortisol and adrenaline to not peak as much as it would while you're on the go, and you're feeding yourself, right? So that's going to magnify the hyperglycemia. It's going to worsen insulin resistance. So within that nutrition, we really didn't cut back on anything. We replaced it. We added education. And we are also looking at the stressors in that first part of the routine. And that's it.
I love that.
I do too.
So you have mentioned a lot here, just intermittently, about fiber. And I do feel like that a lot of people that receive a diagnosis of prediabetes or the first time they've been diagnosed with diabetes, not a single person may mention fiber to them. What is fiber doing to help them?
Great question here. So fiber in general is in our foods, okay? If you had to think about simplifying this, anything that is coming from animals doesn't have fiber. And everyone thinks that, I have to just eat grass if I'm going to be eating fiber, but that's not the case. as humans, our intestines are long. So for them to contract, for them to process your glucose, your other molecules when you're eating, we all need fiber. And that's how we are made. Our human body is made of intestines, and that's why we need the fiber, so that once the food is getting into the intestines, we're absorbing all the nutrients, we are contracting it, the leftover is called feces, and that's being evacuated, and you have a good bowel movement. So fiber is helping in that process, and fiber is in your fruits, in your vegetables, in your nuts, in your seeds. We talked about chia seeds. So it is something that is a large component of your food, other than carbs, other than protein, other than fats. Those are macronutrients. You don't want to complicate your nutrition by thinking that I'm eating so many carbs, I'm eating so many proteins, I'm eating so many fats. But if you just outline my plate, does that have, fiber 50% of the times? And that fiber can actually have protein. The fiber can have carbs. Your beans and lentils are carbs, but they're also filled with protein. They barely have any fat, and they're rich in fiber, right? So fiber is what we need to move our bowel and to sustain that absorption that we are dependent on for our fuel, and also to build a gut microbiome. That is our trillions and trillions of good bacteria that we have in our gut, in our intestines, which feed on fiber to make you stronger, to build your vitality, to actually help you live longer. So fiber is beyond the carbs, protein, and fat. Fiber is what can be in foods which are already rich in proteins and carbs.
Sadly, I feel like a lot of people get fearful of foods that are high in fiber. I know a lot of patients will be scared to eat fruit or beans or oatmeal because they're worried about carbs, and tend to lead more towards eating more animal protein to try to help improve their sugar.
Yeah, as women and as men, we have, different ranges of how much fiber we need. It could be 25 grams, 35 grams, 45 grams. But think about at least 25 to 30 grams minimum, be it a male or a female. Now, this is also complicated, that how am I going to sit and calculate my fiber? So just break it down to breakfast, lunch, and dinner. And when you mentioned about the oats, right? So the more processed oats are, that's your instant oat. That is, every fiber, it's being shelled out from it, and you don't get much of the whole grain. But if you're looking towards steel cut oats, or even for that reason, rolled oats, they are less processed than instant oats. And now you are combining it with other sources that are not necessarily carbs, but they are actually fiber. So you could add some of your nuts there. You're adding some chia seeds there, and that's helping you to shift the absorption, what's happening in the stomach. So you could add some nut butter to it. You could add either water, or if you prefer unsweetened plant-based milk, your choice. You can add some yogurt, right? So now you're combining it. When you combine carbs, fiber, and your ingredients into it, along with proteins, you're changing the absorption of your gut. And I'm told this is specifically your stomach. So your gastric absorption, it's telling your blood glucose to rise, that's getting delayed. So it's not getting into a spike. And we have a lot of data on continuous glucose monitor to witness that, but it's gradual. And now you partner that with your physical activity, meaning moving around, right? Just doing 10 squats, or just walking around, or, you're attending a meeting, or you're with students, just doing some leg kicks, or some, wall push-ups. Or I love squats or lunges, because wherever you are, like I teach at my medical school, I end up doing 10 lunges while I'm teaching. And that brings, it's a momentary break even for students, and they could do the same thing. But what that is doing is limiting that glucose spike, which might happen with a good fiber, right? But this might happen in people who have insulin resistance, who have prediabetes or type 2 diabetes. Someone who doesn't and are wanting to improve their insulin sensitivity, the same exact meal in partnership with your post-meal physical activity is going to be magic to improve insulin sensitivity and guaranteed results for patients with type 2 diabetes mellitus. I have strong family history of diabetes. We started with my grandmother's story. I do have some mild acanthosis. I have to make sure my A1C is less than 5%. That's my goal for me. right? And I have very strong family history of my younger first cousins getting diagnosed with type 2 diabetes at age 30, which we are seeing in the United States of America too, that age 15 to age 35 is the steepest rise in patients with type 2 diabetes. So don't fear fiber. It is not necessarily, a culprit to cause the rise in blood sugar, but the culprit is what we are interpreting about fiber. It has to be in a combination. It has to be in partnership with your physical activity. And it gives you a short-term benefit, but it also gives you the long-term benefit, which is improving your insulin sensitivity. And if in doubt, go ahead and use a continuous glucose monitor. Repeat the same drill for like a span of 1 week. Remember, 1 day is not going to be helpful for a continuous glucose monitor. But if you use it, eat the same type of breakfast, improve your physical activity. And I'm talking about like 10 squats or lunges, right? Or just walking if you're elderly, or just, going from your bedroom to your kitchen and time yourself for those 5-10 minutes. You'll see magical improvement in how your insulin sensitivity improves.
Many patients, whether they have a diagnosis of prediabetes, diabetes, lots of people are getting access to these right now. And I think something that can also happen from using this data is get fearful of all foods, just worried about anything that could cause a peak or whatnot. And I know I get this question asked a lot, so I'd love to hear your take on it. When we have this data and we're looking at how our body responds to a meal, are we more concerned when we have like just a big peak that comes down really quick? Are we more worried about mild elevation that just lasts a long period of time? Is it just the area under the curve? What kind of concerns do we have when we look at this data based off of meal we just had?
So first, just don't worry about anything. When you start using a CGM, you know that I'm using it so that now I know what's happening inside me, other than me verbalizing, what I feel or what conditions I have. So an awareness tool, the first time is very important, and then gradually when you're used to using a continuous glucose monitor, then you can buy a lot of teaching points from it. Don't buy that worry that, oh my gosh, I just had 2 strawberries and my blood sugar went up to 180 and I should stop eating strawberries. That's the wrong conclusion that you're gathering from a continuous glucose monitor. Just in general, when we didn't have CGM, right? Just common sense that when I'm going to have something sweet, which is a fruit, for example, it is going to raise my blood sugar. And how quickly that comes down speaks about my insulin sensitivity. CGM, they are not giving you blood glucose. They're giving you sensor glucose, right? So there's underneath the skin, we have some fluid and that's giving you some glucose data. So it's not a blood glucose. That means it's not 100% accurate and it's not 100% real time. The patterns are going to be important rather than thinking one spike and I make a conclusion, this food is bad for me or this food is good for me, but you follow it along, right? And that's why we talked about, using the same type of a meal for 7 days and then assessing, is my physical activity helping? How much is the spike? Can I reduce the oats from there and add more chia seeds? And that's going to be your personalized tweaking for your meal to avoid a massive rise in your glucose level. So don't worry, just observe for the first 7 days, right? Now, there is a large spectrum, so I cannot generalize this. If I have a patient with type 2 diabetes, I already know their A1C is elevated, and I'm just teaching them to use a continuous glucose monitor. Their blood sugars are probably going to be in 200s or 300s at baseline because their A1C is elevated, right? So the education for them is going to be different. Here, it's more awareness that just let's watch your blood sugars for one single day, 24 hours. And lo and behold, they have this awareness, oh my gosh, my blood sugars are in 200 nonstop, no matter what I eat, right? Even if I'm sleeping, even if I'm fasting, it's just 200, right? For them, the education is going to be different, that can we bring your baseline down? Can we just trust on water intake? Can we trust movement? And do we need help with medications or are we okay in the next few days? And then talk about foods. Because otherwise, what are they going to do? My blood sugars are 200. I better stop eating, right? Or so in those scenarios, when the blood sugars are 200s, then of course I will counsel them that, hey, let's avoid simple carbohydrates, right? Because any fruit intake, anything from 200 is going to take them up to 400, right? So your baseline is important. So in those scenarios, 1 week we are observing, but we are trying to bring their baseline down. And in those scenarios, going on a lower carb intake, more water intake, increasing physical activity so that their base, or with support of medications if that's needed, so that we can bring their baseline down to say a safer range, which is maybe 150s, 160s in the next 7 days. And now train them about that, hey, fruit is not bad for you, okay, but how are we combining fruit? How are we bringing into the picture? Because trust me, I have seen this over decades, that if their blood sugars are high, baseline is high, and you tell them that fruits are great for you, oh my gosh, that, 2 pieces of strawberry or even 1 piece of strawberry brings about this fear. It's literally like a PTSD that I will never have fruits because it took me to 300 and I felt more miserable. So that's very important in CGM education, that one, it's not 100% real time, it's not 100% accurate, but the patterns are dramatically helpful. And over time, and after 2 days, you can rely on the blood sugars more often or the sensor glucose more often rather than the first 24 hours if you're placing the sensor or the CGM the first time.
And you've talked a lot about physical activity. Can you just tell us how physical activity helps someone's blood sugar?
Everyone talks about lifestyle interventions first, and then comes medication for prediabetes, type 2 diabetes, or even prevention of heart disease. And the magic number for them is 150 minutes of physical activity through the week, divide it however you want to, and that'll help you. Or weight loss of 5 to 7%, and that's going to help you improve your glycemic control or your risk for heart disease. Now, why are we talking about physical activity or so on? I'll just share a patient. So what was it, 3 or 4 weeks ago, I had a 73-year-old new patient. The wife actually wanted the consultation because he's got type 2 diabetes, and recent in November, he had a bypass surgery. And she's saying, I want my husband to live a life. I don't want him to die before I die, right? So that was the main reason for the wife. The husband was like, I don't have to do much about my diabetes. My wife cooks. My wife injects the insulin. So the wife is doing everything. I don't have to do much. She is checking my blood sugars and so on. So first date was, let's just use the CGM, right? So a lot of training for a 73-year-old, the tech support and so on. The first week he got comfortable with the CGM. So that reduced the stress for the wife that I have to check his blood sugars twice a day and stick his fingers. But after the placement of CGM, what we discussed is post-meal walks. And why that is important is your muscles, and this is a common board question for us in endocrinology, your muscle cells are the only cells which are not dependent on insulin for that glucose to be driven into your muscle cells. Other than that, your fat cells, your liver cells, where the insulin resistance is pretty robust, they all need insulin for the glucose to be driven inside the cell. Your muscles don't. So you have the power to contract your muscles as much as you could and let that glucose circulating in your blood enter into the cell. But it also helps you improve insulin sensitivity because it doesn't let your pancreas poop out more insulin in your bloodstream because you're the one taking care of the glucose, right? So you are the one making sure that the post-meal walks, or I'm doing those squats or lunges, I'm building some muscle strength. No matter what age you are, you can just reflect on any form of physical activity, contract your muscles. If you're sitting, just move as if you're pushing on the gas pedal, and let your calves work, and they'll take on that extra glucose from your bloodstream into your muscle cells and bring your insulin resistance down, but also your glucose spike. So that's why physical activity becomes a key important foundation for treating blood sugars or high blood sugars, and also to improve insulin sensitivity. We touched base on stress a little when we were talking about that adult who is on the go during the morning hours, and just sitting with yourself, or taking those 2 extra breaths, which are just for yourself to calm yourself down, or just to listen to yourself, or just to understand that, yes, I'm alive and I'm breathing. It really works great in terms of not letting your cortisol and your adrenaline just be on the rise. And it also helps us to get out of that fight and flight mode that we are living in 24/7. It could be just through our thoughts, or it could be in form of an action, which triggers the cortisol. And both those hormones are notorious to tell your liver that, hey, manufacture more glucose. It's called hepatic gluconeogenesis. And that leads the rise in glucose levels, which you see on your continuous glucose monitor or, in your blood test. So that's why learning on how I can not necessarily control stress, but how can I respond to such scenarios and how can I avoid certain reactions that are not necessary during my day-to-day routine, which allows me to live in a calmer way rather than in that flight and fight response mode. So the go, 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 go personality will always lead to these levels of blood sugar. Baseline, they may be just slightly higher. And we witnessed that on CGM, that, I slept. Oh, it was a weekend today. And my blood sugars were just, average was way better than what it's usually from Monday to Friday.
It's so nice having that data to be able to actually see what we've talked about for years for people. Yeah.
Exactly. Yeah. And you really don't have to check your adrenaline level or cortisol level because that becomes the influencer world who are not medical professions. It's just this glucose data or just how you're feeling will tell us that, is your cortisol higher than what your baseline is because you're in that anxiety mode or you're just worried about something or you don't have time to rest. So that's a big discussion or a large part of discussion that we have in patients with insulin resistance prediabetes or type 2 diabetes. The sleep aspect of it, because you touched on it, is also very crucial. And the handout that I was talking about from diatribe.org, it talks about, various kinds of sleep disorders or sleep disturbances which impact our glucose. And now we know more because we have the Oura Ring, we have so many sleep apps, but the CGM data again is a very useful tool. If I am eating late, if I'm working late hours, if I have different times of bedtime and different types of times for waking up daily, these are all going to affect our blood glucose as well. So the first thing is your quality of sleep. If it's impacted, get that addressed. It could be a sleep study. It could be maybe a perimenopause, menopause shift. So get that taken care of. It could just be how your bedtime routine is, which is causing disturbance in your sleep. It could be environmental factors. It could be your thoughts that I am constantly worried and concerned about something. So, getting the right expertise. But all this just keeps us awake. Our brain waves are still firing. Our neurons are still working. So even if you're trying to rest physically, if your brain is not getting that rest, which it deserves, there is this circadian rhythm disruption in how your cortisol is produced and how your growth hormone is produced and how your adrenaline is being synthesized 24/7. And that will impact our blood glucose, but it has direct effects on insulin resistance. If you've noticed in data, most of the heart attacks happen early in the morning, between that 4 a.m. and 6 a.m. phase. Think about it. Why does that happen? Right? Because our hormones, most of them have the circadian rhythm. Our body is made to work in sync with nature. And if we are trying to disturb it daily, nonstop, 365 days, it is going to impact our hormonal and metabolic health. And that, in concert with that is a part of insulin resistance, prediabetes and diabetes. Again, if you're not sure, use these, tools, use the continuous glucose monitor and have that discussion about patterns with your clinician and address it one by one. So don't think that you have to just use or learn every skill today to improvise your blood sugar, but it could be one thing at a time. But addressing all of these are going to be important for your health.
That's amazing. And I think just a good summary for our listeners, if you just had to tell someone these 3 habits have the biggest impact, are there 3 that you could pull out for our listeners to get them started?
Water intake. Okay. It's very crucial, a good amount of water intake. Just think about 50 to 70 ounces, no matter what weight you are, what height you are. And the reason I say that is it is essential for us. And dehydration will lead to spikes in blood sugars. And the second one in our discussion, I would say post-meal activity. Anything. If you are getting some coffee or if you're having breakfast, lunch, or dinner or some snack, think about movement after a meal, after a snack. It's really going to be resourceful and the reasons we talked about. The third thing I would say is breath work and the calm on the go, which we have we don't need a medication for bringing that calm within us. It's just breathing We have so much science, the ancient tradition of breathing. There's yoga, there's pranayama, but just, search for hummingbee breath work or box breathing. But that is the way how I see, even on CGM, where the blood sugar, especially the early morning rises or late night rises, by practicing these techniques can bring your blood sugar down, your blood pressure down, and just, connecting with your own cells.
I love that because that was all three of those are not what patients are hearing on a regular basis at an appointment. And so
none of those were restrictions.
Right. And I love that because it's much easier to think, oh, I can just add this instead of take away this out of my life, take this. So thank you for those. Those were great ones.
And I think the other thing that you've really said today is just thinking about how can I make maybe something I'm already doing or eating more beneficial to me. So you don't have to give up your fruit or give up something you enjoy, but can you add it in with something else that's going to let it have less of an impact on your sugar? So I think it's a great way of thinking about it.
Yeah. And if you feel anything is questionable, just use a continuous glucose monitor. You will know what happens after 7 days. Yes.
I think there's so many things out there on social media and people are getting information in so many different ways. What resources would you tell people are reliable to look for recipes or guidance on nutrition and activity and things?
Sure. So, one thing, there are lots of resources. We've built our own resources. I have a breathwork guide, I have a diabetes guide, and so on. But, follow physicians. I feel like and they're both certified physicians, just like your podcast. One, because you'll end up connecting and you'll get some real life stories. There is, a lot of intelligent and simplified resources. The platform that I talked about, diatribe.org, diatribe.org. And it is, you'll have resources on nutrition, on type 1 diabetes, type 2 diabetes, insulin resistance, and a lot of great recipes. American College of Lifestyle Medicine has a lot of tools on stress reduction, as well as, recipes. One thing I tell patients is, because they love changes, is literally go to ChatGPT and tell that, I have hip pain, or I don't like to walk as much, but I can do these things. Can you outline me 3 activities or 3 steps that I could do in terms of exercise and build it in my schedule? Or literally say that this is how I work from 7 a.m. to 7 p.m. Can you help me find 15 minutes for activity? And it'll be your assistant. So use AI to help you if you're not able to carve out time for yourself. And same thing with nutrition and recipes. I would just look at one meal at a time and focus on where you want to start. But in consult with, a clinician or a healthcare professional, because that will be a great teamwork to bring about the outcome that you're desiring.
Great. Yeah, it is. Now you're the second one who's given us some good advice recently on incorporating ChatGPT to help you get those outcomes that you need. Thank you so much for giving us all these thoughts. And I think this will really help patients kind of understand how the progression changes from insulin resistance to prediabetes to diabetes. And really what we want people to take away from this today is you do have control over your health and you can improve things. So know that you can make a difference, and it doesn't take changing everything, but just one little change at a time will make a difference.
We'll see you next week.